right, welcome back, everybody. We've got last but not least today. We've got James Alaniz who will be sharing with us, and so we're gonna just jump right into the session now, because I know there's a lot of good content we're fitting into this hour. And so let me tell you a little bit about James. So James Alaniz is a highly experienced care manager specializing in elder care and guardianship. As a leader care manager for the Good Shepherd Fund, he has spent years working with vulnerable adults and their families to navigate complex medical and ethical decisions. His expertise includes end-of-life care planning, crisis intervention, and ensuring that clients receive the best possible care while respecting their autonomy and dignity. James frequently consults with medical teams, social workers, and legal professionals on best practices for managing guardianship cases involving significant medical and personal challenges. And so, James, I'm going to pass it over to you, and you got the mic.
All right. Thank you very much. I appreciate it. Hello, everyone. Today, we're going to be talking about critical choices, medical decision making for conservators and healthcare representatives. Again, my name is James Alaniz, and I work for the nonprofit Good Shepherd Fund. And the agenda that we're going to be covering, as you can see here, is a lot, but I do want to add a note that this was originally a 3-hour presentation, so I had to whittle it down to one. So there's a lot of things I'm going to be touching on, and there's just so much more information that I could have talked about. But we're going to touch on pretty much everything that you see here. So for beginning, I kind of wanted to put out the NGA, or the National Guardian Association, standards for decision making. In other words, what a guardian. So it varies from state to state. In California, we are called conservators. We are also guardians for clients who are under the age of 18. Over the age of 18, we call them conservatees. And so in different states are different. So if I say guardian and conservator, I'm talking about the same thing. So number one, in standards for decision making, a guardian shall identify and advocate for a person's goals, needs, and preferences. Goals are what are important to the person. Preferences are specific expressions of choice. So first, the guardian shall ask the person what they want. So this means just asking the person themselves, now depending upon their intellectual disability, they can either answer you or they can't. All right. So that's the first thing we're going to do is ask them, what do you want? Second, if the person has difficulty expressing what they want, the guardian shall do everything reasonably possible to help the person express their goals, needs, and preferences. So this would include giving them a pencil and paper, a writing pad, sign language, any kind of device or aid that can help them express themselves to let you know what they want. Third, they get to the point where they cannot do that. Even with assistance, they cannot express their goals. Shall the guardian seek input from others familiar with the person to determine what the person would have wanted? So this would include, again, the client is having trouble expressing themselves, expressing their needs. So we're going to go down to the home staff, the people who take care of them, the medical facility, family. We're going to ask them, what do you think they want? What do you think they would be choosing right now? And finally, only when the person's goals, needs, and preferences cannot be ascertained may the guardian make a decision in the person's best interest. So this is when it falls upon you to make that decision for the client. So getting to that point where you have to make a decision, especially when it comes to medical decisions, how you do that is you have to have as much information about your guardian, about your conservatee as possible. You want to have all the information, medical information, physical information, psychological, in order to help you make a decision, because many times medical decisions do involve potentially life-threatening conditions. And so you need to make sure that you have all of your ducks in a row, so to speak, lined up. Additional steps that the guardian takes. So in California, conservator is mainly responsible for medical and legal decisions. Okay. Now, if we were just a regular conservator doing our due diligence, that's all we would do is handle medical and legal decisions. But in my opinion, it goes so far beyond that. It goes way beyond consent for medical decisions. In addition to what we do for our clients, we ensure the individual's safety by securing essential needs like food, shelter, and clothing. establish a safe and supportive environment, ensuring the appropriate level of care is in place. And this is important to confirm that the facility providing care is properly licensed and capable of meeting the client's medical and personal care requirements, safeguarding their medical stability. So basically, what you need to understand, what that means basically is that you want to make sure that your client is living in a facility or a group home that is licensed to provide the level of care that they require. In California, we have classifications of intellectual disability. Slight, moderate to severe. We have level 1, level 2, level 3, and level 4. A level 1 client would be pretty much almost self-sufficient, but they do need assistance with medical or financial decisions and making food for them, up to level 4, which is severe, semi-vegetative state, nonverbal, or behavioral issues. So it's a very high level. The homes and regional centers, the homes and facilities that we deal with also are level 1 to level 4. So level 1 is a very slight care facility. Level 4 is a very high level secure facility. And so you don't want a level 2 client in a level 4 home. Conversely, you don't want a level 4 client in a level 2 home. So you want to make sure that the home or facility is capable, licensed, and willing and able to care for the client in the way that they deserve. So you might want to ask yourself, why is this important? Well, the level of care provided plays a critical role because it can hasten the progression of existing conditions. It could make things worse for them if they have psychological issues, if they have behavioral issues, if they have anxiety, depression. Being in the wrong environment, being in a strange environment, a cold environment, can alter this. It can hasten the progression. It can make things worse. Potentially shorten the individual's lifespan. I'm not saying that you put them in the wrong house, you're going to kill them, but I do feel that if they're in the wrong house, it could lead to other things that can hasten their demise. It could happen. It can cause vulnerable clients to fall through the cracks. I'm sure we all understand what that means, resulting in unmet needs and increased risk. So as conservators, we have to ensure that every detail is addressed to protect the well-being and dignity of those under our care. So a good example of this, of a client falling through the cracks, would be Linda. Linda was a client of mine in Southern California. She is a 32-year-old female residing in a group home with 3 other residents. She was diagnosed with a mild intellectual disability. She had anxiety, she was bipolar, and was attention-seeking with hypochondriac tendencies. So the group home would call me. They were calling me a lot, reporting issues with Linda's behavior, describing her as acting out, and demanding an increase in medication to manage her. So that kind of stuck with me. It was really weird when I heard them say, I mean, they were literally demanding an increase in medication to manage her. So in layman's terms, what that means for me, because I have a background in medical history, that means dope them up so that they don't cause any more problems, is what they're saying. And they wanted me to do that. And I suppose in certain situations, a conservative might just go ahead and say, okay, but if you want to be conscientious, if you want to be conscious of your client and their wellness and trying to help them live their best life, that's not going to go over too easy. So I said no. I said I wasn't going to do that until I saw her, because her acting out could be anything. It could be any level of acting out. So I wanted to make sure I knew what was going on before I would say yes and consent to a medication increase. So I visited the home multiple times over 2 months. I would go at all times of the day, unannounced. I'd go in the morning. I would go during lunch. I would go during shift change. I would go in the evening. And so I would suggest doing that as well. When you visit your clients, go unannounced, go at different times of the day so you can see how the interaction is between the staff and the other residents and your clients. Again, you want to make sure that you're going to be there for maybe an hour or 2. They stay there for 24 hours. They live in that environment. So you have to make sure that they're in a safe place, right? So over these multiple visits, I noticed patterns in the home that raised concerns about the environment rather than Linda's behavior being the primary issue. In other words, Linda was acting out, but there was something going on externally, environmentally wise, that I was beginning to see. And in particular was one resident. She was 6 feet tall, at least 300 pounds. And she regularly exhibited disruptive behaviors. I mean, she would just suddenly bolt up and charge for the front door or charge for the kitchen and start grabbing things. And so it took 2 to 3 staff members to redirect her. And that's all the staff that was in there at that home, was 3 staff members at all times. Sometimes there'd be a nurse, or sometimes there'd be an admin manager, but most of the time it's those 3 staff and then the 4 residents. So this disruptive behavior occurred consistently during each visit and appeared to be the source of Linda's heightened anxiety. In fact, at some point, I even saw her put her hands over her ears to block out the noise because it was bothering her that much. So what I take away from this is that it highlights the importance of thorough assessment, not only of your client, but of her environment, where she's at. You know, I take I take their word for it. I'm not going to tell the home that you're lying. You're not telling me the truth, but I do want to make sure that I'm understanding the question. I'm understanding the problem completely, as opposed to them saying she's acting out, she needs more medication. I need more than that, right? So we're going to do assessments on both the home and the client, because sometimes the environment and interactions within the home play a more significant role than initially perceived. So my take from this was that Linda was acting out due to loneliness and lack of attention. The other residents' disruptive behavior was draining staff resources, leaving her feeling neglected. She used to go out on outings into town and stuff, and she used to go outside and do things. So they were feeling isolated. Now, I can't speak for the other residents, but I'm pretty sure that this was going on with everybody. Because of that one resident that was taken up all the time. It wasn't because Linda was acting out, because she was just attention seeking. But at the same time, when you're being neglected and your only way of expressing yourself is through acting out, that's what you're going to do. And that's what Linda did. And what the real kicker for me was the home staff and management shared the same concern I did about the resident dynamic. In other words, they agreed with what I had of my assessment. They knew that she was a problem. And in my head, I'm thinking, why didn't you do anything about it? Why did you let this go on? But I wasn't going to lay any blame. I wasn't going to get mad at them. I just knew that they agreed with what I was saying. So I actually made the suggestion to move her to a higher level of care. They didn't do that. They actually hired additional staff, which is fine. That was okay with me. So they brought in additional staff. They hired one more person to ensure that Linda, as well as other residents, received the attention and care that they needed. So, and the result of that, it was almost immediate. Her behaviors dramatically improved, and she was still a diva personality, but she became much happier, more outgoing, more sociable, and she began participating in outings to town. And it took several months for all of this to happen, but in the end, the result was exactly what I wanted. My client was living her best life. If I had just followed the suggestions of the home and increased in medications, increased psychotropic medication to a patient who doesn't need it, is going to have metabolic issues. They're going to have it's going to mess them up. And what would have happened is she would have ended up in the chair, drooling all over herself, numbed out. Which for the home may have been great for them, right? Because no problem anymore. But for my client, it would have been a quality of life issue. She wouldn't have been living her best life at all. And that was not acceptable to me. So just by doing an assessment, by doing a little bit of more thorough investigation before you actually come to a medical decision, it made the whole difference in the world for her. So this case demonstrates that medical decisions such as increased medication must be made holistically. Her behavioral issues were not due to a medical condition, but rather the environment. By addressing the true cause of the distress, which was lack of attention and support, her behaviors improved without the need for increased medication. So this highlights the importance of assessing environmental and social factors before making a medical decision. Another case example regarding medical decision is Alfred. Alfred is a client of mine, again, in Southern California. He was a 69-year-old male with Down syndrome, profound intellectual disability. So I would call him a level 4 ID, or intellectual disability, nonverbal, dependent on a ventilator. His limbs were very, very tightly contracted. His legs were crossed, so much so that his right heel was up on top of his left hip. And, the left heel was up on the right hip, very highly crossed, and his arms were very crossed up on his chest, very contracted. And he had a neurogenic bladder, which required a Foley catheter. So a neurogenic bladder is a medical condition in which the bladder has a sphincter, which is a ring, kind of a ring muscle that stays shut. And the bladder, there's a urethra that is attached to the bladder, which leads to the outside with urine. When you urinate, that's where it flows out. There's a sphincter right there that keeps everything tight and keeps urine from flowing out. Neurogenic means that for whatever reason, due to his illness or due to his age or condition, there's no brain signal to that sphincter. There's no control. So the sphincter muscle itself is part of the autonomic nervous system. So it stays shut on its own, but with no brain connection, it stays open, it's flaccid. So when he would build up urine, it would just flow right out. So that required the use of a Foley catheter, which I'm sure all of us know what a Foley catheter is, but it's a long rubber hose that is inserted in through the urethra, into the bladder, and a balloon is inflated to keep it from coming out. So this is where the urine flows into. It flows into a bag. The problem with that is that's a long piece of rubber hose into your urethra, and there is just ample opportunity for bacteria to get in. It is supposed to be done, it's supposed to be inserted in a sterile condition, a sterile procedure, and it has to be removed every a certain number of days. It has to be taken out and then replaced again. So there's always the opportunity for infection, and that's what was happening. When I took him on as a client, that's what was happening. That's what I noticed as I looked at his medical history. He would have a urinary tract infection, a UTI. So he'd spike a fever, he'd go to the ER, they'd get antibiotics, he'd go back to the facility. And this was a cycle, an endless cycle: UTI, fever, ER, antibiotics, back home. Almost every other month, this was going on. And especially for older people, a UTI for us, for people who are younger in their 40s and 50s, I mean, it's uncomfortable, but we can deal with it. It's not too bad. But for somebody who's 69, older seniors, UTIs can actually lead to death if it's not treated correctly. They can become septic. And there's lots of other mental and neurological issues that can happen because of an untreated UTI. So I just saw this vicious cycle. They were not treating what was actually going on. They were treating the symptoms. And it was exacerbating. The focus was treating the symptoms rather than addressing the root cause, which was the catheter. This cycle raised concerns about potentially exacerbating other health issues and shortening his lifespan. Now, this happened late 2020, 2021, right at the height of the COVID. So again, that was huge, having to remove him from a hospital or from his facility to the ER and then back to the hospital. There was just so much. And in fact, he did catch bronchitis one time. He did get pneumonia from one time, what we call nosocomial infections that you get from other areas. And he did actually contract COVID, which I'm pretty sure came from ER. So this was going on during the whole time. So I went and did an assessment and a thorough evaluation on him. And I brought up the suggestion of inserting a suprapubic catheter. Now, suprapubic is a medical term. Supra means above. Pubic means is referring to the pubic bone, which is that bone in front of you. So if you push down to where your bladder is, you can feel a kind of a bony prominence, a hump. That's your pubic bone. It kind of circles around part of your pelvic girdle, and right above it and behind it and down a little bit is where your bladder is. It's about the size of your fist. So what they do is they put in a feeding tube, which is a G tube, which is basically like a gastric tube, just above the pubic bone into the bladder, directly into the bladder, and that it collects urine that way. So what that does is it takes away the urethra as the entrance point. And the suprapubic catheter doesn't have to be replaced. It has to be replaced, but not very often. It's like a feeding tube. And it's much, much safer. The percentage of infections is much, much lower by doing that. So I talked to the medical team about it, gave consent for the procedure, and the pubic catheter was inserted. And since the procedure, he has not had any further UTI, not a single UTI since then. And this, like I'm saying, this was back in 2021, and now we're in 2025, and he has not had any issues with that again, simply because of that little change, simply because I knew my client, I knew the medical history, I knew what he needed. So having all that information helps me make a medical decision, which is going to uh, increase his quality of life. Because I can't imagine how painful and uncomfortable a UTI is, but just imagine if you are unable to speak, you're unable to verbalize and tell you, hey, I'm in pain, I'm hurting. And he had this all the time. So by eliminating that, it was a win-win for him. So this case illustrates the importance of addressing underlying medical issues rather than just treating the symptoms. By considering alternative medical intervention, a suprapubic catheter, the cycle of infection was broken and it improved his quality of life. And, thoughtful medical decisions can lead to more effective long-term outcomes. So we're going to talk about key steps for client assessments. So this is one of the things that's very important for me is doing a client assessment, a hands-on physical assessment of your client. Not only of the facility and the group home, but doing an assessment on your client as well, because you're going to be able to make medical decisions for your client much more easier and with much more knowledge if you have a thorough knowledge of who your client is, what their medical history is, what their allergies are, what their surgeries are, what their diseases are. You having all of this information so that when something does happen, you'll be able to handle it. It'll come and you'll be able to handle it without having to think, oh my God, I don't know what to do because I don't know anything about him. By having all this information, that's going to put you at an advantage every single time. So ask questions. Do not hesitate to ask questions when assessing your client's needs. Every single one of my clients, when I first met them, I assessed the environment too. I would talk to, and if you ever go to a facility or a group home, I don't necessarily talk to the RNs or the managers or the administration in charge. I talk to the people who are actually handling my clients, the nursing assistants, the aides. I always ask them. And my quote to them was always, walk me through a day, which sometimes I would get a confused look. And I would just tell them, I would explain to them, walk me through your day. What time do you get them up? What is the first thing that you do? Okay. And they tell me, we shower them, we shave them, we give them a bath, we let them go to the bathroom. Okay. What do you do after that? And so I just go on through the entire day. What do we do before breakfast? What do you do after breakfast, lunch, all the way through bedtime? This is going to give me a really clear understanding of daily routines and the care. And I'm going to be able to assess that they're getting good care or they're not getting good care. Physical assessment. Don't be afraid to lay hands on your client. Okay. It's, if appropriate, to assess their physical condition. This hands-on approach can reveal important insights that aren't always visible. So what questions should I ask? The type of questions depends on your client's specific condition. Is the issue internal or external, as I like to say it? Can it be observed, or is it something that you can't see? So if someone says my shoulder hurts or my knees hurt or my elbow hurts, these are things that you can see. You can look for redness, you can look for swelling, you can feel heat from a fever or an infection. These are things that are external, you can see, and you can address them, you can treat them right there, as opposed to internal. My stomach hurts, my head hurts. These are things that you cannot see and cannot be assessed right away because we don't know. Stomach pain is very vague. It could be liver, it could be gallstones, it could be an intestine somewhere, it could be the colon, could be constipation. All kinds of different issues pop up. And you may need to call in a medical consult if you need to. But these are internal versus external. And how do I know my client is doing well? Knowing what to look for and asking the right questions will go a long way in determining your client's health and safety. Pay attention to their appearance, their mood, and their behavior, and ask about their daily routine and any changes. If they're able to talk to you, ask them how they're doing. What are they doing? Watch what they do when you come up to them. Do they wince when they see you, or do they shy away a little bit when you reach out your arms to give them a hug or something? Those kinds of things are red flags for me. In doing your client's assessments, building relationships is extremely important. When conducting assessment, don't make it a you versus them situation, meaning don't antagonize the staff or the home or the facility. Don't come in there as, high and mighty conservator. I'm going to make sure my client is doing my job and you guys are doing your job and this and that. Don't. You have to remember that we're all working toward a common goal, the health and safety of your client. Because if you come across as a threat, particularly by asking too many questions without building rapport, it can create resistance. Establish a positive relationship with the staff or facility, which will make it easier to collaborate on decisions that impact your client's care. So I can honestly say that in all the day programs and the facilities and the group homes that I work with, I show up, I come in unannounced, and right away it's hey, it's James, and they come in and say hi to me, or they'll call me at all hours of the day. He had a fall. My client had a fall, or he has a fever. We're going to take him to ER, or they're having difficulty breathing or something. They're right there to call me when anything happens, because I built a rapport with them and made them feel like they're part of the team, which they are. And it's very important that they don't see me as different, that they don't see me as the conservator, to be afraid. I don't want to show up and then them say, oh my God, Jimmy's here, and then them freak out and everybody lose their mind. I don't want that. And I don't have that. And I'm very thankful for that, because in the end, when I have to make a medical decision for them, they're going to know that I'm going to do everything in their best interest. And I'm going to know the history. They're going to know the history. And so it's going to allow me to make a better decision when it comes to medical decisions regarding the health of my client, the health and safety. So key considerations while assessing your client. Are they verbal or nonverbal? Can they communicate their needs effectively? Or do they need somebody to speak for them? Mobility. Are they ambulatory, semi-ambulatory, or non-ambulatory? Can they walk? Do they need help walking, or can they not walk? Disabilities. You want to assess both physical and intellectual disabilities, like Parkinson's, dementia, Alzheimer's, cerebral palsy, Down syndrome, stroke, contracted limbs, on top of any other type of issues that they might, intellectual disabilities that they might have. Psychological issues. Be mindful of any psychological challenges or behavioral concerns. Depression, bipolar, intermittent explosive disorder. On top of other types of physical and intellectual disabilities, you could have, what we call a fully loaded client, somebody who has a lot of different things wrong with them. Comorbidities, we call them. These are medical conditions that may impact their care. So a comorbidity would be something like a chronic long-term illness like diabetes, high blood pressure. These are obesity. Obesity is a comorbidity. So you could have somebody who is Down syndrome, obese, has high blood pressure and diabetes, on top of having depression. So that's a full plate right there. And so any one of these things, anything going wrong with any one of those issues can cause a whole myriad of problems. And then it's going to have you responsible to make medical decisions. So having knowledge of this, being aware of the medical condition and the medical history is going to help you make a decision much better if you know your client. First impressions matter. Are they dressed and groomed appropriately? Do they or the home have any noticeable odors? Do they smell? Really, basically, when I give my clients a hug, I give them a smell. I smell. Did they shower today? Do they smell fresh, or do they smell like they haven't been washed, or do they smell like urine? Any kind of thing. Or does the home or facility have a weird smell to it? Look at the small details. It is the small things that really, really count. It's the small details that add up to big details. Are their fingernails and toenails trimmed and cleaned? Check for dirt and smudging in the creases of the skin. This can indicate neglect. Thankfully, I've never had come across that, but it is possible. These are things you need to look at. Does your client give an appropriate response when asked a question? Do they look at you directly? Or do they look at the staff member before asking you? These little things you need to observe for demeanor and engagement. Are there limitations to the phrase living their best life? So while our goal is to always help clients live their best possible life, it's important to recognize that quality of life means different things for different individuals. Particularly those with profound disabilities or terminal conditions. It is essential to have history of medical interventions with the individual's overall well-being. Respectful communication. Always assume that your client can hear, see, and feel your presence, even if they're nonverbal or unresponsive. Even though it is essential to keep the client included in decision-making, there is a time and place for these discussions. So you never discuss health decisions in front of the client, because they may be in the semi-vegetative state, but For me personally, I have never seen a medical report yet that says that definitively that someone who is comatose or semi-vegetative is not there. I have yet to see that. I have to assume. I assume every single time that they can see me, they can hear me, and they can feel my presence. And I will always do that until told otherwise. So make sure that you're not discussing things about them right in front of them as if you're thinking they're not hearing you, because they can. And reflecting on your role, I think this is important. It's natural to ask yourself, why are we doing this if they don't even know we are there or what is happening to them? And you almost feel like there are times when you use a lot of resources, you lose a lot of time and energy for something that a client doesn't even know you had. And this could be something as simple as arranging for a visit, or getting them a wheelchair, or maybe extra pads for their bed. As a conservator, your role is to advocate for your client's well-being, regardless of their awareness. Your decisions are based on preserving their dignity, ensuring their comfort, and considering the best possible outcome, even when they may not be fully aware of your actions. The way I see it is, a lot of my clients do not have a voice. And as an advocate, you are their voice. So you represent them. So do your best on their behalf. Key responsibilities for conservators: to keep them safe and comfortable. Your role as a conservator to ensure that your client is safe, comfortable, and well cared for. Again, food, shelter, clothing. Monitor for skin conditions, skin breakdown. Okay. Maybe some of you may not be thinking about this, but it's something to think about the next time you visit your client, the next time you visit the home or the facility. You do a physical examination on them, because the last thing you want is to get a call in the middle of the night saying they have an ulcer on their tailbone or on their elbow that you knew nothing about and they didn't tell you about. But if you're beginning to see the beginning signs of redness, you can track it and you'll know what's going on. Okay. And so by skin breakdown, I want you to pay close attention to the areas prone to pressure and friction, particularly what they call the bony prominences of the body. And these include the back of the head, the tops of your shoulders, the elbows, the wrists and fingers, knees, heels, the hips, and the tailbone, the coccyx. These are very, very vulnerable to pressure. Tissue paper skin. I'm sure we've all are aware of that with our much older clients. Their skin is so fragile, it can easily tear and break down and be torn. So you got to be aware of that. Be aware of the bruising and the blackness that comes with that. And remember also, pressure causes friction, friction causes heat, and heat breaks down tissue. It's as simple as that. You want to look for signs of redness, swelling, and early ulcers, decubitus, so you can track them, so you can make notes. You notice some redness on the shoulder, so the next time you see them, I'm going to look at that shoulder again to see if it's worse or if it's gone away, because it could be a one-time thing or it could be an ongoing thing, right? Again, also, if your client is nonverbal and they're laying on their elbow against the metal frame of the bed for 2 hours before they're turned again, they're not able to say anything. But if you're doing examinations every time you see them and you notice that, you can call for elbow pads, you can call for repositioning, you can just do everything you can to make sure that this is the issue is not happening, continues to happen. Bacterial risks. Bacteria thrive in 3 conditions: darkness, warmth, and moisture. And where do you find that? You find that in the folds of the skin. You need to inspect the folds of the skin. I'm talking about under the breasts, in the folds of the stomach, in the folds of the fat, the abdomen. You look for redness, you look for irritation or a yeast smell, which can indicate infection. And you will know yeast when you smell it. I will tell you that. So don't be afraid to get in there, put some gloves on and examine your patient, and I'm not saying just go in there, be respectful and then cover, keep their privates covered, but look in there and look for signs that they're being washed properly, that they're being cared for. Because if there's a smell, if there's dirt or grime in between the folds of the fat, then they're not washing them properly. They're not being cared for appropriately. And these are issues that have to be addressed, because down the line, they're going to develop illnesses. They're going to develop ulcers. They're going to develop something. And then you're going to have to make a medical decision on that. So by doing all of these things, you're basically preventing yourself from having to make a medical decision if you're keeping track of the wellness of your clients. Dentition, you want to check the condition of teeth, dentures, and gums. Look for food particles, bad breath, mucus buildup, redness of the gums. If they wear dentures and they're not in their mouth, where are the dentures? Are they on top of the nightstand? Or are they in a cup sitting in solution like they're supposed to be? These are little things, correct, but they do make a difference because I can't imagine having somebody put in a pair of dry dentures without any uh, paste, or they've just been sitting all day on the counter. They're not clean. So it's again, it's the little things that really make a huge difference. So part of being able to make an effective medical decision means gathering information. The more information you have, the more the better equipped you will be to make to develop an appropriate care plan. So this means client demographics, and it's very simple, right? But we're talking about age, gender, living situation, past medical history, past surgeries, past hospitalizations, current medications, what they call the MARS, M-A-R, Medical Administration Report. So one question I'd like to ask you is if you go to a group home or a facility, can you ask for the medical report? And can you look at the MARS and can you ask for a medication list? Absolutely. As a conservator, as a guardian, absolutely. And I would suggest you doing that. Every one of my clients has a current medications list. And when I visit, I check the MARS and I make sure that their medication list is matching to mine because I don't want, there have been instances where medications have been changed or introduced or stopped and I didn't know about it. So by keeping track of it, you will know, and it keeps you better aligned what's going on with your client. Allergies, diagnosed conditions, we want to make sure we have all of their diagnosed conditions and how they're being managed. Are they being treated? So this is a comprehensive overview, and this ensures that conservators and healthcare representatives can make informed decisions that align with the client's medical needs. And, in the end, it will improve their quality of life. And that is really what we're looking for, what we want. So a good example of this is to pull or not to pull. Now, this was a 49-year-old female with moderate intellectual disability. She had ADHD, she's nonverbal and self-harming behaviors. And during the time that this was going on, she was having a bit of a mental crisis. She was acting out, she was acting very erratic, bizarre, self-harming behaviors. We couldn't quite pinpoint what was causing this. But I get an email from the home and a phone call. They requested consent for wisdom teeth extraction. And verbatim, they said, dentist says it needs to be done. We just need your consent. That was it. That was the email. And I'm just not about to say, oh, okay, yeah, let's go ahead and do that. I felt rushed and concerned about the mental state of my client. The client was in a mental crisis at that time. So I was concerned about how she was doing. And then on top of that, wisdom teeth. So to add context to that, I didn't know she was having problems with her teeth. So that was on the house. They didn't tell me this. So this is all new. So I'm not just going to say, oh, okay, you need a wisdom teeth pulled. Dentist says it needs to be done. Okay. So I didn't. I again, my head went to assessment. I took a step back and I asked the questions and I asked them, is she in pain? The answer was no. Okay, check. Is she having trouble eating? No. Check. So why are they wanting to have the wisdom teeth pulled right now? So ultimately what I did was I went to speak to the dentist himself, and the stars aligned for me on that day because when I showed up at the dentist office, he happened to be there in the hallway talking to some other nurses, and he heard her name, and I actually ended up talking to him. Most of the time it's a runaround. It takes forever to talk to a doctor, but this time I hit all the ones on that one. And I spoke to him and he said, I saw her a couple weeks ago and she's not in immediate need right now. I'm thinking in a couple of months she'll probably need her wisdom teeth out because it's starting to impact a little bit, but not right now. She doesn't need them out right now. And so that was an eye opener because from the home was telling me she needs her wisdom teeth out now. We just need your consent. And the dentist himself said, well, that's not a rush. And so my decision was, let's wait. Let's wait on this because remember at this time she was having self-harming behaviors. She was having a mental crisis. if we had taken her in and removed those wisdom teeth with all the pain and recovery that's involved with, I can't even imagine what she would have been going through on top of her mental crisis, on top of the pain she was receiving. So I said, no, we're going to wait. And the home was very unhappy with the decision. But at that point, I said to myself, I'm not here to make you happy. I'm here to care for my client. I'm here to care for and it was a good home. It was an adequate home. But, at that point, I wasn't really taking into consideration their feelings because I was only concerned about my client's feelings and their well-being. So we waited for 2 weeks and the client's mental crisis had passed. So we scheduled the procedure and I signed the consent form, authorized it. The extraction was completed and everybody was happy, and so was my client because she was past her medical. So it just goes to show that you really have to understand completely everything that's going on before you make a decision, before you jump to a rash decision, even though the home wants it. And we all want to make everybody happy. We all want to do what, make the home happy. But sometimes there are times when you need to step back and stop and ask the questions, ask important questions. So the takeaway from this is you always put the patient's needs first. And I'm sure everybody knows that, and everybody agrees with me on that. Understand the situation. Speak to the healthcare providers directly. Because I think what happened in the end was there was a miscommunication. There was something wrong in the translation between what the dentist had said and what the home interpreted it as. They thought she needed her wisdom teeth out now. You needed consent now. And the reality was that wasn't true. Maintain independence. Don't let the home or external pressures influence your decision. This is huge. This is important. So by waiting, I prevented unnecessary stress on the client because in the end, my client's well-being was the priority, and the decision led to a positive resolution for all the parties. So again, this was a win-win for me and for her. Erring on the side of caution. Should we take into account the differing opinions of family members, staff, and the medical team when making decisions? Absolutely. Take into account their opinions. However, it's important to maintain a balanced approach. What does erring on the side of caution mean? Does it mean playing it safe and avoiding major decisions? Does it mean letting others help you decide to avoid responsibility? Does it mean agreeing with what others say because it relieves you of the burden? The reality of it is it doesn't mean avoiding responsibility. It just means making thoughtful, informed decisions by gathering all relevant information, consulting with the necessary parties, and considering your client's best interests. So be prepared. The takeaway from that is be prepared. Preparation is your best defense. Being well prepared is the best way to handle any situation that may require a life-changing decision. Take the time to gather complete information, weigh the options of others carefully, and prioritize your client's health and well-being when making decisions. Navigating complex relationships, family dynamics. Oh boy. So, some family members, I'm sure we've all had that experience where they may try to avoid or they may try to control decision making, even if they're not the legal representatives or legal decision makers. They're self-appointed decision makers. Be aware of these people who may assume a role that they're not entitled to. Overbearing parents. Sometimes parents struggle with stepping back, which can complicate care decisions. Disinterested siblings. On the other hand, some family members may not be involved or care enough. When you reach out to family members, and I've had family members literally say, "I don't care. You're the conservator. You do what you think is right." Is there money involved? If there's a trust involved, financial interests can skew family involvement, especially in cases like setting up a special needs trust. Be mindful of family dynamics, especially in cases with aging parents and a sole child who may carry the full burden. And sometimes you're on your own. There may be situations where you are the sole decision maker. So be prepared to act independently, relying on your understanding in the client's best interest. Again, this falls back on the more you know about your client, the better you're going to be able to make medical decisions. Do family always matter? While family involvement can be beneficial, there are cases when it could lead to complications due to misinformation, neglect, personal opinions, self-serving intentions. All of these people, they think they know what's best. They think they know procedures. They think they understand surgical procedures or illnesses or diseases, and they voice their opinions. It's important to listen to them and to take into account their feelings and their opinions. But in the end, you are the one that counts. You are the appointed decision maker. Sometimes family interference becomes detrimental to the client's care. They can get so involved and so interfering that you may need to take steps to limit or negate further contact from them. So the key point is, do not allow family dynamics to complicate or obstruct your ability to make sound medical decisions in the client's best interest. If you are making a decision in your heart that you feel is in your client's best interest, then you are making the right choice. I've always said, go with your gut until told otherwise. Go with your first instinct until proven otherwise. It's always the best way to go. Can you be objective? This is important. As a conservator, it is crucial to maintain objectivity when making decisions that impact the well-being of your client. Avoid letting emotions influence your decisions. Emotional involvement, especially from family or staff, can cloud judgment and lead to biased decision-making. Objectivity, what does it mean? You know, the definition. The quality or character of being objective means making decisions based on facts and evidence without being influenced by emotions or personal feelings. Challenges in the end of care life, emotional, understanding age-related decline. So as we all know, we all experience this as your clients age, their physical systems begin to shut down, which is a natural part of the aging process. One of the first signs of decline is often the loss of smell, which can often lead to the loss of taste. So now they don't want to eat anymore because they can't smell the food, that they're disinterested. It results in reduced appetite, which results in weight loss and muscle mass reduction. Ambulation changes. As balance deteriorates, clients may stop walking foot over foot and begin to shuffle their feet to avoid tripping and falling. Another thing you might want to do when you assess a client's home or facility or in their room even is look for rugs and carpets. Look for anything that may prove to be a tripping hazard for them, because as they get older, they shuffle their feet. And that's why they do it, because they don't want to trip on the rug. Hearing and vision loss. Diminished hearing and vision can lead to confusion and frustration as clients feel that they are losing control of their environment. It's a very awful thing. Now, couple that with being nonverbal, not being able to express yourself and having to experience all of these things. It can be really traumatizing. So as a conservator, is it essential to understand the realities of aging and end of care, and to remain objective when faced with emotional challenges from family and loved ones? Balancing the client's best interests with medical evidence and legal requirements ensures that decisions are made ethically and responsibly. Another thing I wanted to add on the family dynamics is legality. A lot of times there have been certain instances where my client's family has said, if you don't do this, we're going to sue you for neglect. We're going to sue you for damages. We're going to sue you for endangerment, all of these other things. And that's a real issue. And that, for some people, that can influence their decision. That can cause them to rethink, or that can cause them to doubt themselves. And that's one of the worst things you want to do, is to doubt yourself, to doubt your decision. And sometimes that can happen, especially in family dynamics. So just try to be objective. Understanding failure to thrive. Now, most of the time when we think of failure to thrive, we think of babies, right? Everybody thinks of babies, failure to thrive. But it also occurs for older adults. It's a symptom. It occurs when an older adult experiences a loss of appetite, which means reduces intake of food and fluids and calories, and weight loss coupled with decreased physical activity. They may become disengaged from social activities or people. Common symptoms include memory loss, difficulty thinking, and trouble with daily activities such as preparing meals, getting in and out of bed, walking, bathing, dressing, and using the bathroom. Contributing factors can be social isolation. They're being moved into a residential facility, but they know nobody. They have no clue where they're at. They don't know anybody. They don't want to make friends. They recently lost a loved one, whether it be a wife or a husband. And they have an increased need for care, which means they have a loss of control over life decisions, which makes them depressed. And it makes them not want to go on. That's a failure to thrive. I have a client that I used to see in Oregon. He would spend most of his days in bed in his pajamas because he just didn't want to get out of bed. And he had a dog, and he would often forget about the dog. And staff of course took care of the dog, but he even forgot about his dog because he was just so depressed. Um, and failure to thrive. He wasn't eating. He would come out, eat a little bit, and then go back and lay in bed. So these are things that we need to watch for, especially when you're making your visits, um, looking at the demeanor and the reaction of your clients and their personality. So this is the end of my presentation. And like I said, this is just 1 hour of a 3-hour presentation. So there's a lot more that I wish we could have covered. But if there's any questions, I would be more than happy to answer them. I'm going to look up in the chat area. Are there any questions that anybody might have?
Hey James, there are a few that came through. Let's see. There's one that came through in the Q&A area, and it said this, and this was probably 30 minutes ago, so you may have covered it or covered aspects of this, but it says, brand new CPGC here. This is Claire. I had a client over medicated in a skilled nursing facility without the staff notifying, much less asking me. As it turns out, he had valid reason for acting up, which has now been addressed, and he is out of the facility. I wouldn't have known about the over-medication if I hadn't gone to visit him and found him a completely changed man from the guy
Okay.
I had been working with before. It's been resolved. The issue that was causing him to be PITA has now been resolved. He no longer has the problematic behaviors, and he is living elsewhere. Is this just a matter of me not knowing to stress to the facilities that they must notify me if they change his medication, or is it on them, or is it on both of us?
That's a very good question. And I would say it is on them. Um, when I have a client come into the facility, that's one of the first things I tell them, as I want to be made aware of any changes in their condition. Um, it's again, it's not on us, it's more on them because they are the caregivers and they should be telling you of anything that is going on, any changes. And yeah, it is on them. They should have made you aware of all these things. They should have made you aware of medication changes. Because again, we're dealing with medical decisions and legal decisions. And that medical, it involves changing the medication. It involves introducing behavioral systems, restraints, new medication, all these types of things. They need to be made aware of it. And if you can establish a good relationship with them, um, then they'll call you. Then they'll tell you. But it also is on you in the part where if you're not receiving any reports or anything, then then it would be your responsibility to find out, because a lot of times we may think everything is going well for the client and everything looks great, but we don't actually know unless we get there to watch them. I can't tell anything that's going on in my client with a phone call or with a Zoom meeting. I actually have to be there, and that's why I like visiting my clients, because I see them. I physically see them. I can put my hands on them. I can look at the MAR. I can do everything that I need to make sure that they're being well cared for. And it's very easy. Oh my gosh, it is so easy to miss things, for things to not be seen. And so by being diligent like that, you can catch these things. So it was by no means your fault that this wasn't caught. I think is the facility's responsibility to have told you that.
All right, and we have one from earlier on in the presentation as well. So this is from Chick, and then the question was, does the G-tube bother the client? I had one in one of my clients, and he frequently winced and on occasion pulled it out. Is your client comfortable?
That again, that depends on the level of intellectual disability. If your client knows it does, I imagine it does bother them. I'm not sure if it's painful because I know he doesn't pull on it. I'm not even sure if he knows it's there. Um, but yeah, it does. If you pull on it, it could cause him to wince. Another thing is the danger of them pulling it out just as much as the danger of pulling a Foley catheter out. As far as I know, when it was put in, he's never grabbed it, he's never touched it, he's never reached at it. And again, as long as it's been inserted properly, as long as the area around the skin is kept nice and clean, when you're looking at it, always look there. There always tends to be a tiny bit of redness around it, but you're looking for redness. You're looking for irritation around the skin. That shouldn't be there. It should, as long as it's kept nice and clean. Most of the time, I like to see a bandage. It's a bandage with a slit cut in the middle of it that goes around the Foley tube, just to keep it nice and clean and keep contaminants from getting into it. Those are also good. And I saw a comment there that said a low profile G tube works best. That's exactly right. Yeah, low profile T tube. And urine is very irritating to the skin. That's why he was having so many issues with it. And I was so thankful that once we put this catheter in, his urinary tract infections went away. And that was just that was great, because then no more fevers, no more trips to ER, no more antibiotics. And so that was a win for him and for me.
Well, lots of comments, but no more questions out of all of that. And so, just want to say thanks so much, James, for being here. And
You're
unfortunately,
welcome.
we get to see you tomorrow, later on in the day as well.
Yeah, tomorrow, I believe at 10:30, I'll be giving a presentation on end of life decisions, and you may see some parallels. You may see some similarities between what I'm talking about here and what I'll talk about tomorrow, because they're both I think they're very closely related. The ideas of making medical decisions and end of life decisions, they're both very similar. So, I just happened to catch this comment here from Jen now. It said, "What is your reason for not involving a client in medical decisions?" So that was actually asked of me last year when I gave the presentation. When you want to assume that they're there, if I know that my client, even that was a very good question, by the way. And sometimes, if we're going to do a procedure and my client is semi-vegetative and not even conscious, there are times when I would still talk to them as if they were there. What I'm talking about is sometimes I've heard conversations in which they're doing really poorly, they're doing bad. I wish they wouldn't do this, and just talking randomly about medical stuff that they really probably shouldn't be hearing. But if in instances when I was going to consent for a procedure or we were going to do something, I would talk to them as if they were there, as if they were listening. But I didn't want to come across as saying I don't involve them. But then again, whether we're dealing with the level 1 client who can probably understand what is going on, which I will actually talk about tomorrow, or a level 4 client that has no idea what's going on, you still want to assume that they're there and they can listen, and you still need to talk to them and involve them, even if they're not able to respond or talk. So that was a good question.
Well, thank you, James. Thank you, everybody. That's the end of day 1, and we'll kick things back off tomorrow morning at 8 o'clock in the morning. And feel free to hop in earlier. I think the room will open at 7, or the Zoom room will open at 7:50, and we'll get started a few minutes before, and then that first session will start at 8 o'clock. So, see you tomorrow, and talk to you soon.
All right.
Enjoy some
Thank you,
rest.
everybody. Thank you, Luke.